Welcome to our webinar, Billing and Coding for Concussion Care. As of January 1st, 2019, the billing codes for psychological and neuropsychological testing were updated. This webinar will give you an overview of how the codes changed and how you can use the new coding system to maximize reimbursement for neuropsychological tests like Impact, Impact Pediatric, and Impact Quick Test. I'll go over a few opening items, introduce our presenter, and we'll get started. Treatment options and tools presented are some of many that are available. All individuals in control of content disclose no relevant financial relationships. Other continuing education disclosures can be found in your course information document. Learn the must-know tips to get the best reimbursement rate for your concussion care services. Review the 2019 updates to the CPT codes. Discuss the commonly reimbursed CPT codes for concussion management and how to document your services to get high reimbursement rates. And our course objectives? At the end of the course, attendees should be able to restate the updates to the CPT codes as of January 1st, 2019, identify commonly used CPT codes and rationale for using each code, and restate a sample concussion clinic workflow. And our presenter is Jim Gerke, Chief Operating Officer at Impact Applications. Prior to joining Impact Applications, Jim was the Vice President of Sales and Marketing for Psychological Assessment Resources, a leading publisher of psychological assessment instruments, software, and other related materials. He served as adjunct professor in the Department of Education at Trinity University. His research has been published in 15 peer-reviewed scientific journals, and he has made over 200 presentations at state, regional, and national meetings. Jim has served in advisory, technical, and review roles for almost 20 industry-related boards and professional journals, and Jim currently resides in Tampa, Florida. Jim, thanks so much for presenting this overview on the 2019 Billing Codes update.
All right, this is an overview of the 2019 update to billing changes that have been made in regards to CPT codes. We're going to review what this means for your working with insurance providers, how the coverage is proposed to change, and if you're a psychology or billing under psychology, CPT codes will provide a specific focus on that. Then we're going to move to how this might sit with the clinic structure, the required documentation, and then some case examples related to billing. All right, what changed in 2019? For the first time, there's been a separation between the professional and the technical services for billing. And kind of how that plays out is specifically for psychologist administration versus technician administration. There's also now a new requirement to differentiate between administration of a single test versus a battery of tests. In 2019, the standalone codes are for primary or basic services, and then there are some add-on codes that are specifically picking up the additional effort and additional time associated with a primary service. So what that means is that you're going to bill a primary service under specific codes, and then those codes have what you might have been familiar with as modifiers, and that's for the additional work and the additional time. What changed in 2019, you can see here, is that there are at least 6 codes in the psychological testing service codes that have been removed. The ones probably you're most familiar with are 96118, 96119, and 96120, and then we will review what those have been replaced by. The testing and evaluation services in 2019 are going to be under 96130, 96132, or 96133. Now, in 2019, there's been an attempt to define what is professional work, and as such, the elements of professional work are integration of patient data. So looking at information across history, possibly going and looking at other test data that might be available on the patient. Then there's the interpretation of standardized test results and clinical data. That interpretation involves not just looking at the scores, but understanding the scores and integrating that with clinical data on the patient. Then there's the clinical decision making. This is the essentially the practice of looking at data and then forming a diagnosis and then ultimately a treatment plan and a report. The information that you would need to formulate a treatment plan obviously is first a diagnosis, and then that all goes into your report. And then lastly, it's providing that to the patient and the family member or caregiver, where in the past that may have been billed separately as feedback. That's not all now under the professional work category. They look at this, when I say they, meaning the CMMS codes, consider the type of facility, which is private practice versus public, and then medical versus mental health payer, and then who is paying within the region. So who's the lead agency, basically, who's responsible for payment. And then lastly, finally, the requirement for pre-authorization. So while in the past there may not have been requirements for pre-authorization, there is now a movement to get pre-authorization for the purpose of deciding whether this is an appropriate referral and whether the testing meets the requirement. So, all right. When working with insurance providers, you typically have a patient come to your clinic or your hospital or your practice, and they're referred there for a concussion evaluation, either suspected or unknown concussion. So that's in one case, the primary care provider may have referred the patient to you because they're not sure if they have a concussion, and so you're providing the primary concussion evaluation. In the second case, the patient's already been diagnosed with a concussion, but it's either complicated or they want the patient to be seen by somebody who has more of an expertise in the area. And so the patient is referred to you with a known diagnosis. If the patient's insurer is a large percentage of patient volume, you may have to negotiate some with the insurer. So the way to do that is to call for someone within the insurance, and they typically have a payer benefits line, and you would ask the following questions like, is the desired code covered? What's the rate of reimbursement for the desired code? Are the desired codes covered for diagnosis of concussion? And will they reimburse for services using a concussion diagnosis? So, what you want is to get the insurer to indicate to you prior to you spending the time and the effort whether or not this is a covered service. And if it's not, then clearly the patient would have to decide whether they are wanting to move forward with the evaluation or not. Kind of is difficult if you don't get this answered and then comes in for an evaluation and the patient is then stuck with a large bill. That's not a situation that you want to be in with your patients for obvious reasons. When you work with the insurance providers, the best thing to do is to develop a relationship with somebody there. So whether it's a practice advocate, whether it's a patient rep, somebody in provider relations should be able to help you out. Not all insurances are set up with kind of easily discoverable people, but many of them do have provider relationship departments, and you should seek to develop a primary relationship with a provider relationship person. So when you're, again, continuing to work with insurance providers, if you've taken the following steps, you can negotiate on the existing contracts, because insurances want to be able to provide reasonable care. They don't ever want to be seen as denying reasonable care to a patient. That's both bad PR, and it could end up in a very bad situation for them. So if it's reasonable care, and the patient is not currently covered, you can work on the patient's behalf to get them covered. So in one instance, the patient may be extended out of network medical benefits for your services, and typically out of network leaves the patient paying a larger portion of the total bill, but nevertheless there is still coverage of much of the bill. You could also be assigned an in-network medical status for certain procedures. So even though you might not currently participate in the network for that particular insurance, you could be assigned a temporary in-network status. And in the best case, you actually could get admitted to the panel. If that's your desire, many times insurances look to add providers in low service areas or in specialties that they don't have great coverage on. If the insurance provider doesn't offer a solution, again, you should get as much information from the insurer so that you can relay the information to the patient. And then it's really up to the patient to decide, do they want to discuss this with the insurance? Do they want to appeal the decision? They always have the right to appeal the decision. And again, in the sort of last ditch effort, is there an agreement that the patient can come to with you to reimburse you for services rendered? Sometimes providers use ICD-10 codes. There's a table here with the SO6, OX1, OXO, OX1, and OX2. And they basically are three types of concussions. One is without loss of consciousness. One is with loss of consciousness for less than 30 minutes. And third, the OX2 is loss of consciousness for anywhere between a half hour and 60 minutes. So again, depending upon the nature and type of concussion. When we look at neuropsychological testing, which is the basis for you to provide the billing and diagnosis for the concussion, a neuropsychological testing is typically provided by a psychologist with specialized training and a specific expertise in this type of testing. Now, in many states, physicians also can provide neuropsychological testing, or a technician under the supervision of a licensed psychologist or physician can provide the testing. Now, in the case of a technician providing the assessment piece, they're simply administering the test. It's the physician slash neuropsychologist who will review the results, come up with a formulated diagnosis, and then discuss with you, with the patient, what the next steps might be. That's where the testing and evaluation services are always performed by the professional. In no case should a technician complete the evaluation, meaning they shouldn't be responsible for the diagnosis and or providing feedback to the patient. Same with the written report. That should also always be done by a licensed psychologist or physician. And then lastly, it's best practice to provide the information back to the patient in a face-to-face meeting. In neuropsychological testing, there's really two types of tests. One is paper and pencil, and the other is computerized. Paper and pencil testing, while having been around for a long time, have it has a number of drawbacks. Mainly, it's very time consuming, and there are potential errors in scoring and administration. With computerized neurocognitive testing, which forms the basis of concussion diagnosis and management, um, according to the 2016 Berlin Consensus Statement, computerized neurocognitive testing suggests athletes suffer impairments within a week of concussion. So there is some data that suggests that the test is good both proximal or close to the injury as well as for some period of time thereafter. Baseline testing, while not mandated on a broad basis, has been found to be quite helpful to the clinician in interpreting results of post-injury testing and as an educational tool. This is particularly true if you are testing a subject that is special needs in some way. Clinicians who do seek to formulate a diagnosis regarding a concussion should never base their decisions on a single test. In fact, the more data that you can gather to come up with the diagnosis, the more accurate that diagnosis will be, and the more useful then your treatment planning can be off of that diagnosis. Even though impact is a broad-based neurocognitive tool, consistent with what we were just saying here, it alone is not sufficient to formulate a diagnosis. Impact is a stable measure of neurocognitive performance over a fairly long period of time. So when you look at what's called a reliability coefficient, impact has found to be reliable over a 12-month period. So it has a long stability period for test results. When you look at the psychometrics of the test, the reliability, the validity, the clinical utility of the test, all of this is enhanced by incorporating other data. So whether it's other testing data, other psychological or behavioral data, impact is a single tool, but in combination with other tools adds to the diagnostic accuracy and utility. So when we look at why a concussion should be covered and why you would use a neuropsychological test to cover the concussion event, concussion is a traumatic brain injury. It's defined as a bump or blow or jolt to the head that disrupts normal functioning of the brain. And typically the way concussion is determined is that prior to participation, an athlete is given a baseline test. If you think about it, it's essentially testing them prior to any event. So the baseline test is, if you will, it's how they are in a healthy state. And then computerized neuropsychological testing, a post-injury test, is administered after a concussion, and the results are compared to the baseline. And it's that in combination with other data, as I've said, that form a comprehensive picture that gives the clinician the necessary information to evaluate concussions. All right, so how does that all get coded then when you are in a clinical setting? So in the past, you might have coded a concussion evaluation as 96116. That's now two codes in 2019. 96116 is the first hour, and for each additional hour, you will code a 96121. So 96116 has been replaced by a 96116 and a 96121. 96118 is now 4 codes. 96118 is completely gone. The base code is 96132 for the first hour, and then 96133 for each additional hour. And that includes the time it takes you to select your test and then to make decisions and to interpret the data. There's also a 96136, which is if the testing takes less than an hour or 30 minutes. So anything up to an hour, it would be 96136, and then if it's 40, 45, 50 minutes, you would add a 96137. And again, that includes the time spent selecting and scoring the tests. 96119, like 96118, is now broken into 4 codes based primarily on time again. So 96119 for the first hour is 132, and for each additional hour it's 96133, and also again includes test selection, decision making, and test interpretation. If you are less than an hour, 96138 and 139 are for the first 30 minutes and any subsequent 30-minute period. 96120 is now 96146, which is psychological or neuropsychological test administration with a single automated instrument via an electronic platform with an automated result only. So neuropsychological testing done by a computer where the feedback is provided by a computer. So one of the things that is not yet available but should be available soon is the reimbursement rates. The reimbursement rates for neuropsychological testing administered by a technician and evaluated by a psychologist are thought to going to be increasing by somewhere in the neighborhood of 6 to 6.3%, and then testing administered and evaluated by a psychologist. So the difference here is the test was actually administered by the neuropsychologist. That's estimated to decrease 3%. And then there will also be different rates for non-facility services. Now, if you're a medical doctor, whether it's MDDO, there are time-based codes 96101, 102, 103 that you might want to become familiar with. And then also 90801 for a psychiatric diagnostic interview, or 90862 for pharmacological management. And those are specific only to physicians. When you consider the billing within a clinic structure, one of the important things to understand is that the clinic structure is based upon what's reasonable and customary for a number of patients being seen in a day. So you want to be careful not to have too many patient visits billed in a specific amount of time, particularly if you have a limited number of providers. So 1 unit of time base code is conveying to the insurance provider that's anywhere between 30 and 60 minutes. If you were audited on that, you'd have to have some sort of documentation to prove that you actually spent the time there. Typically, in a mid-sized clinic, you're going to look to see 13 to 15 patients a day, with an average of 1 hour to hour and 15 minutes for a clinic visit. Now, we're not talking about general health clinics, by the way. This is specific to a concussion clinic. Students can come into clinic on a fairly frequent basis, sometimes daily, depending upon how severe their symptoms are and how they're being managed. And while they're in clinic, it's not uncommon to administer other kinds of testing, particularly if you're trying to get at some of the various specific types of cognitive dysfunction that the patient might be experiencing. If you want to consider a concussion model for your clinic, we provide one where, if you have an orthopedic clinic with 5 MDs and a neuropsychologist who is the clinical director, with one of the surgeons being the medical director. You have an athletic trainer who serves as the clinical coordinator, and then a master's level person or a medical assistant collecting patient data. And if you're lucky enough to have interns running around, that provides additional hands on deck. But they must be supervised by the clinic director as part of their general practicum. When you bring the patient in, it's typical, as in all clinics, to have an initial evaluation, whether it's a medical history intake or where the patient fills out questions related to the specific reason that they're there. You want to get their demographics, any relevant history, medications, etc. You also want to make sure that you get relevant concussion history, if they've had multiple concussions or if this is their first concussion. You want to get some sort of symptom scale completed on them, whether they do it or someone who is very familiar with them helps them. Sometimes patients are so concussed that it's hard for them to get through a long questionnaire, so having a parent or guardian there with them is often helpful. Then you administer the impact test, and again, if the patient is very concussed, it's not uncommon for them to have either a very long testing session or in some cases not even be able to complete it. So you want to be mindful of how many symptoms they're reporting and how severe those symptoms are. If they're able to, again, you want to get additional data on them, whether it's cognitive data or psychological data about their symptoms and about their mental status. The neuropsychologist should also perform a clinical interview, and if he or she has concerns about vestibular functioning, they can also do a VOMS. And then after all that, it gets put together, and the data is used to come up with a diagnosis in concert with all the medical team and recommendations for a follow-up treatment plan. That's particularly important for the ATCs, and if there are any physical therapists in the clinic who are most likely going to be in charge of the follow-up. Where we are is we are waiting for additional billing guidance from CMMS, and specifically the reimbursements for the various codes and the time codes, and by professionals. So once that becomes available, the course will be further updated at that point. So if you have any further questions, please contact us and check back for an updating of this course.
Thank you, Jim. Again, folks, this course is intended to be a brief overview of the 2019 billing update for neuropsychological testing. As new information on reimbursement rates and case studies from practicing clinicians becomes available, we'll update this webinar. Please reach out to us at info@impacttest.com if you have any questions.